So I'm going to let you in on a little secret and backstage setup behind this clinical communication resource. You may have noticed in the interviews I've done in the past, it doesn't start from a cold open. It doesn't start from me saying go and someone introducing themselves. It starts from an ongoing conversation once I've done the introductions. A conversation has already started. And to help guests get warmed up and get comfortable with me and talking, I ask them some kind of warm-up questions. These are things that they can easily answer and just helps get them comfortable and get them going. So far, I've released a few of these warm-up questions in the past over social media, but some of the more recent interviews I've held on to them until now. So today we've got some unreleased footage from conversations with Joe Gibson, Nick Lividas and Ian Reilly. Even though this is bonus footage, there's still quite a lot of useful information inside, which I hope you enjoy. If you find this useful, please do go share it with others, subscribe. You can also contact me with any stories, dilemmas you need help with, or questions. It's clinicalcommunication@outlook.com, and we can read them out here. So our first bonus footage content is from Joe Gibson's recording of how to shoulder difficult conversations. And in this bonus footage, you're going to hear us discussing a specific rotator cuff question not often asked, and how to build rapport with a certain patient group. So, first thing, this is a little question which I was very curious about when I searched this earlier. Everyone bangs on about their rotator cuff muscles. According to ChatGPT, which of the rotator cuff muscles is the heaviest?
Subscapularis.
Bloody, I came straight out with it. Can you order it from biggest to smallest? Weight.
In weight, subscap. Now I would say then infraspinatus, then teres minor, then supraspinatus.
Now, it's put teres minor last. It does say at the bottom here, ChatGPT can make mistakes.
Now, who am I going to argue with? No, well, that's why I was just because it just depends I was just trying to think of the pennates. That's so sad in infraspinatus and teres minor. Yeah, I'd probably, I'd definitely say subscap's the biggest, for sure.
Yeah. Interesting. I typed in what's the order and it gave exactly what you said, subscap, infra, supraspinatus, teres minor. I asked it before, which is the heaviest, and it said infraspinatus. So it can't make up its own mind.
So actually it disagrees with itself.
It disagrees with itself.
Yeah, all I know is that if you were a cannibal, you'd want to eat subscap because it's by far the most meaty.
Is it?
It is. Very meaty muscle.
The other one is more about building rapport and relationships. You've worked in Liverpool for many years. What, for people like myself and many others who don't work in that area, what have you found from working with many Liverpudlians helps particularly build rapport and trust with them compared to other people?
Telling them who you support in football.
Yeah.
Definitely. First question, are you a red or a blue? And humour's massive in Liverpool, absolutely massive. They just have the most incredible natural wit. So I think not taking yourself too seriously, and just smiling and being a nice person. I mean, they genuinely are out to communicate. They are naturally just an incredibly friendly and open kind of group of people, really. It's been a real kind of lovely place to live, and that's why I've stayed.
Good. So our next bonus footage is from Nick Lividas and his episode of how to discuss steroid injections, which is one of the most popular ones I've had so far. And in this bonus footage, we're hearing about some very unique stories he's heard with injectables and also an update on where we are with stem cells. Nick, what are the weirdest places you've heard people be injected with steroids into?
To be honest, most people that have had steroid injections have had them in either joints or soft tissues. Some people will say, I had an injection for my shoulder pain. I'll say, do you want to show me where the injection was? And they point to the middle of the humerus because that's where the pain is. But ultimately, the source probably was the shoulder joint. So, for some reason, they've had the deltoid insertion injected, which probably wasn't the source of the pain. So you do come across some of those sometimes. Other areas are, and this probably is from research, the BMJ where people were having steroid injections in the buttocks and the gluteals for their shoulder pain.
Oh.
And that was a kind of a well-cited trial that found similar results to putting a shot of steroid in your buttock than in your actual shoulder.
Yeah.
And at 6-week follow, both groups seem to do equally well. So it's a practice that didn't catch on, thankfully, because I probably wouldn't fancy it myself. But yeah, it raised some questions in terms of, well, what is the mechanism of which steroids are taking effect?
That wasn't that long ago, was it?
About 2009, that paper from
Okay,
the BMJ.
fine.
Yeah, it's
Okay.
over 200 citations now, so it's well known. It does have some limitations, but yeah, it did kind of raise some questions in terms of what is the mechanism behind how these things work. But I guess probably the more interesting and intriguing factor around injections is more the huge array of different injectables that there are available
Okay.
beyond corticosteroids.
Okay. Well, we're aware of steroids, which we're going to discuss. We're aware of other substances, hyaluronic acid, for example, you can hear or people get injected in. What are some of the weird and more interesting things you've heard people be injected with in the past?
Well, I guess some of the listeners are probably familiar with PRP or platelet-rich plasma, and that's probably not as wacky now as we first thought, to be honest. It's becoming more and more not a mainstay of NHS treatment, although some NHS providers do offer PRP, but certainly in private practice and sports medicine. And it does have a growing evidence base, which unfortunately is flawed with a lot of methodological limitations. But we also see, what we call now regenerative medicine in injectables. And one that's really kind of intrigues me is lipogems.
Okay.
And lipogems is a brand name for a device that extracts someone's adipose tissue, usually from the stomach, okay? And it is kind of spun within a kind of a closed circuit device, which kind of aims to kind of hone the growth factors within that lipid kind of layer, and then inject it into the arthritic toe or the arthritic thumb or the soft tissue lesion, whatever that might be. So it's almost like a 2-for-1 injection. You get a tummy tuck and you get an injection at the same time. And it is kind of novel. It's not been around very long. It doesn't have a great evidence base, but it's growing. And certainly, you could go into Harley Street in London and, it would be readily available. But certainly some way beyond being in mainstream MSK medicine right now. But, I think we've got to keep an open mind with things, what the future looks like and all the different injectables that come through regenerative medicine, stem cell therapy. I think it's appropriate and right to be skeptical, as most people probably are, but at the same time, approach these things with a scientific mind of, well, let's see where the evidence takes us and keep an open mind. Probably the most wacky thing I've come across quite some time ago now, around 2009, a number of footballers in the Premier League were going to Serbia for horse placenta treatment. So the story goes, one of the Dutch players had an injury against Italy, and one of his colleagues said, "Oh, you want to go to Serbia? There's this doctor or this guru doing platelet-rich plasma, and it worked for me beautifully well." So the player rang his club. It was Arsenal at the time, and his medical team were actually very skeptical. And the player was like, "Well, I'm going, whether you like it or not. Do I have to pay my own flights?" So the medical team, as the story goes, asked Arsene Wenger, the manager at the time, and said, "Oh, just pay his fare." So he flew for international duty over to Serbia, and met this kind of guru that was starting to treat a number of footballers. And whether the horse placenta was injected or massaged into the injury, there's some kind of disparity. Maybe it was both. But in sports medicine is rife for these kind of things, that one or two high profile players go and then a few others go and it kind of catches on. It makes kind of mainstream media and people start asking this question, well, maybe I need horse placenta for my arthritic knee or my ligament injury. And a few players went across and came back thinking, that's wacky. And kind of the treatment slowly kind of died a death. But for a good probably couple of years, horse placenta treatment was all that all the rage for professional sports people. And that's a risk with a number of injectables that come that have that kind of that sex appeal to them. A few people go, it gets a bit of coverage, and then everyone, of course, wants to go to get that kind of marginal gain in their recovery. And so the horse placenta is probably the most wacky thing I've come across.
Do you know why horse?
I don't know whether horses have got better, more nutritious kind of placenta than anyone else. Who knows? But yeah, eventually the story goes this individual in Serbia has got a private clinic, ended up getting a life-size horse statue in her reception waiting area. So she was really kind of playing on the horse placenta as time went on, and subsequently, I'd imagine a kind of business slowly kind of dwindled away.
Wow. Is she still going now? Do we know? Or
Not sure, to be honest.
wow.
Sure, she may well have retired with a hefty chunk in her bank balance, and
Yeah.
probably no longer needs to work again.
What? I'm just trying to think. Where does one get? Is she just going by the at the vet or the stables and just picking up placentas as the new horses are born?
Maybe there's a booming market for horse placenta in Serbia. Who knows?
Do we? And is there? What was the reason? Like, why horse placenta? Did they ever say what it was?
I think it was related to the kind of the growth factors, the nutrients of the horse placenta that would stimulate the healing process. It sounds pretty wacky on the surface, doesn't it?
Yeah.
Clearly not as wacky enough to get £1 million footballers that are getting paid hundreds and thousands a week, getting flown across on chartered jets to have the treatment. But interestingly, Frank Lampard, according to reports, went from Chelsea at the time. He took the doctor, and I think he lasted 1 hour in the clinic, saw straight through it, and thought, "This isn't for me. I'm leaving," and got a place straight back. So it clearly wasn't for everyone, and some people kind of thought, "Yeah, this is wacky. I'm not staying here," and left.
He took the team doctor with him.
Yeah.
Wow.
I think there was some intrigue, on the medical team's side. If you're sending a player across the world for some non-evidence treatment, I guess it's sensible to send your doctor to kind of suss out what it is the players have been subjected to. And I'd imagine the doctor's kind of impression was, yeah, let's get out of here.
Before we jump into all the steroid stuff, actually, because you said it, I'm curious. What is the situation with stem cells at the moment?
It's very early in the day in terms of knowing how useful they will be. There are a number of providers trialing stem cell therapy for MSK disorders and orthopedic disorders in terms of cartilage regeneration, particularly. They are showing promising results. We need more trials with greater numbers, with longitudinal follow-ups, to have that greater degree of certainty. But it is an exciting area for orthopedics, particularly in terms of kind of cartilage regeneration. So I'm keen to keep an open mind, but the jury is certainly still out on that. But it is an area which, if we get the right kind of funding, and big pharma companies, etc., usually kind of stump up the funding for such trials, it's a promising area of development around MSK and orthopedics.
Could we see it in the NHS in the future?
Quite possibly.
Pending on trials, I guess.
Yeah, absolutely. Obviously, it'll be subject to kind of NICE approval, and it comes down to that cost-benefit analysis, of which we know sometimes that the costs of certain interventions that may be very effective from clinical trials means it might not make the threshold for NICE approval. But yeah, time will tell.
And our final bonus footage is from Ian Reilly, only from last week, discussing podiatric surgery. In this bonus footage, we're discussing the past, present, and potentially future of podiatry. Okay, so Ian, what is the future of podiatry?
Future of podiatry is not particularly rosy. So podiatry has been recognised as one of those professions that is at a risk in the long term. So it's had some investment really from corporate government over the last few years, because although I think podiatry as a profession has got kind of a unique skill set in terms of the guys can do pretty much most things of the foot, not each individual, but across a range. A really good podiatrist has got a wide skill set. However, within that, all the other professions can do a little bit of what we do. So, dermatology would do the skin, nurses would do the wound care. Obviously, orthos would do the surgery. Medicine would do the kind of the medical bits that we sort of starting to stray into. Physios would do lots of the MSK type stuff. So really within the kind of greater width of podiatry, all those different skill sets that many of us have could all be done by somewhere else. Now we kind of bring it together in a kind of unique style, I think, and obviously we've got a particular training to kind of bring things together. But it's not a very glamorous profession, in terms of compared to say physio. There's not a lot of people really wanting to rush out and do feet. It's not the most glamorous part of the body. So I'm optimistic for the future. But yeah, we're not in a great position as a greater profession, and certainly that's been taken up by people on high. So fingers crossed we're still here in 50 years' time.
I've seen it across different parts of where I've worked in the past. When it comes to foot needing support, some people go to podiatry and some people would go to orthotics for sometimes similar things.
Right. So I've got you now. So orthotics you could mean is basically, to a podiatrist, if you said orthotics, they would think about it being an in-shoe insole. But yeah, you could go to an orthotist. And I actually use one of the local orthotics labs because I can refer to them as a consultant. So I can actually get them on the NHS. So I use them and they do a pretty good job. Now, in terms of foot mechanics, insole paradigms, when I trained as a chiropodist many years before you were born, actually, Ben, we were taught to manufacture and make insoles to actually a really good standard. So I've still got some, a skill set, I think, in terms of how to make insoles. But there are different paradigms out there. If I talked about root theory, would you know what I was talking about?
Not a clue. No.
Okay. So these were basically Root, Orion, and Weed were American podiatrists in the 60s who basically rewrote the book on foot function theory. Now, that theory has not really been proven, and lots of the modern podiatrists who really do understand foot function would say that Root has been surpassed by other paradigms such as tissue stress theory, sagittal plane facilitation theory. So there's lots of different ideas in terms of how the foot moves. But what the Root guys talked about was 5 major foot types, and pronation being everything that's bad, and would make insoles based upon how the foot dysfunctioned. The orthotist would have a very different idea, and physios would make orthotics, they'd have different ideas as well. And what I've come to realize, having been really kind of big into insoles before I went into surgery 35 years ago, is that really many off-the-shelf insoles for £15 do a pretty good job for most patients. You don't have to spend £300, £400, £500 for something bespoke. No, I would have podiatrists shouting at the screen hearing that, but that's kind of the reality. And there was some big work done by some Australian pods about 10 years ago to say that off-the-shelf insoles do really well for most people. That's Landorf et al. The Americans are still American pods who do an awful lot of training still in insole therapy and mechanics are still very wedded to Root, and they can't get past it. And we're a little bit more forward thinking now, certainly in the UK. And so the UK pods, some of them are really, really good. So there's certainly a kind of a crossover, but because so much of the theory is unproven and lots of the science is fairly poor, difficult to do a double-blind placebo-controlled trial on a set of insoles. The patient's either got an insole in there or not.
Yes, yeah.
So it's all kind of shades of grey, really.
Is there the reason they're particularly stuck to the Americans, particularly stuck to this Rooters theory still?
It's the training. So it's been quite insular, really, in terms of it's been so big for so long. People, it's like the emperor's new clothes. They can't get behind what they've done because they developed it in the 60s, and the guys who are teaching now were really kind of taught by these forefathers. Really, what they did was they elevated foot function and insole therapy brilliantly from what was done before. They put it forward so far. And as an example, so I do a bit of work for 2 different American groups. And so one of the things that we do, we've had a little project the last couple of years with one of the American groups, and we looked to set some international questions for podiatrists. So I had to look at some of these American questions that had been, using for decades. And was one of my jobs was to look at the biomechanical questions. And their, biomechanical questions were, frankly, by UK standards, outdated, and not just by a few years, but by decades.
Wow.
So I pushed back on the questions and said, that's just not the way it is, guys. And the Americans who'd sent the questions over said, well, how can they be outdated? I was taught by rote. So, people kind of really kind of stuck in the past. So if you have any American podiatrists ever watch this, we'll get some pushback, but that's okay.
Yeah, that's true. It's good to have debate, isn't it? And people to be
very, yeah. But healthy, respectful, sometimes quite robust.
Yeah.
But certainly when I kind of go to American conferences, as I do a lot, I see stuff that would be considered very out of date to a kind of UK, Spanish, Australian podiatry audience where we do some good biomechanical teaching now.
The other thing I wanted to ask before we get into the main chunk of this, you being a surgeon, what is your surgery music when you're doing surgery?
ABBA.
ABBA.
Yeah, love Operation to ABBA. And if I was having kind of like a bad day in theatre, which happens, and I was looking kind of a bit stressed out, if I had a few cases that didn't go well, then my PA would put ABBA on to kind of like lighten the mood, and and with the proviso is when The Winner Takes It All comes on, nobody speaks during that because it's the best ABBA song. Agnetha, the blonde one in ABBA, she had a compilation of her kind of best songs ever, because obviously she'd done stuff before ABBA and then after ABBA, and it's a compilation of 40 songs, and there's only one ABBA song in her best of, and it's The Winner Takes It All, which is ironically about her own divorce. So that's a brilliant song.
So there you go. If you've enjoyed this bonus footage, please do let me know. As I said before, please do subscribe. Please do go share with others. There will be more of this as more interviews are done. Thank you for watching or listening, and I'll speak to you next time.